This seminar is for educational purposes only. It is not a substitute for professional medical advice or treatment. Consult with your medical provider for medical advice or treatment. Although the presenters try to keep the information in this seminar as accurate and timely as possible, the speakers and Mather Hospital assume no duty to ensure the seminar is error-free. The speakers and Mather Hospital are not responsible or liable for any claim, loss, or damage resulting from you viewing this seminar.
Good afternoon, and thank you for joining us today for our HealthyU webinar series. Today's webinar is Can COVID-19 infection increase your risk of stroke? And is sponsored by Jefferson's Ferry. At any time during the presentation, please feel free to enter any questions you may have using the Q&A feature at the bottom of your screen. We'll answer as many as we can within the time allotted once the presentation concludes. Your questions will remain anonymous as always, and I'd like to introduce you to today's presenter, Joanne Loughton. Joanne Loughton has been a nurse for 38 years and has experience in a wide range of clinical, teaching, and leadership positions. Her career mosaic spans many diverse clinical settings in both acute and community healthcare settings, such as emergency departments, case management, and home care. Joanne is currently the Director of Nursing Quality and Stroke Coordinator at Mather Hospital. Joanne, thanks so much for joining us today. How are you?
Welcome, and thank you very much for having me. I appreciate it. I hope everyone will find this presentation to their benefit. Okay, you can change to the first slide. So I have no potential conflicts of interest in relation to this presentation. So the learning objectives of this presentation is to actually understand what SARS-CoV-19 is, understanding the effects of the pandemic on stroke and the stroke care of our patients, the influence of COVID-19 on stroke treatment, the potential prevention and treatment of strokes in COVID-19 patients, the current stroke statistics in our community, and the last few slides will be touching on the Million Hearts and Strokes Initiative for 2022. You can change. So as we're all probably tired of hearing about is COVID-19, but I just want to give you some facts about it so that you'll have a better, clear understanding. So these are some pressing issues and challenges that we had as an organization and that the community had with COVID-19 and stroke. So pandemics in general may promote patients from promoting avoidance to the hospital for emergencies. You know, they have fear of coming to the emergency room. Will there be very many COVID patients in there? Will that present me as a challenge as someone from the community of possibly getting COVID by coming to an emergency room? The other thing that patients look at is there added hospital precautions that may exacerbate treatment delays. So what's going to happen when I come to the emergency room? Do I have to put on all of these gowns and gloves and masks? And is it going to take longer for staff to come in and treat me because of all of these added precautions, which may have prevented patients from coming to the emergency room? Next slide, please. So I wanted to touch a little bit on actually what is SARS-CoV-19. And SARS itself is an abbreviation for an acute respiratory syndrome. That's basically what the SARS stands for. And an acute respiratory syndrome is it's a viral infection that attacks the respiratory diseases caused by the SARS virus. It was first identified in February of 2003 during an outbreak that emerged in China and spread to 4 other countries. That was plain SARS. SARS is an airborne virus, and it can spread through small droplets of saliva in a similar way that a cold or a flu can spread. Viruses themselves are named based on their generic structure and to facilitate the development of diagnostic tests, vaccines, and medicines. The name COVID-19 was chosen because this particular virus is genetically related to the SARS coronavirus responsible for the outbreak in 2003. Although these viruses are related, they are totally different in nature. So actually, what is COVID-19 and why is it so deadly? So this particular virus has something called a spike protein. And these little red things that protrude out that look like appendages coming off this big ball down here are the spike proteins. And the spike proteins that are coronavirus, they bind with membranes in the human cells that they affect. This binding process is activated by a certain cell enzyme called furin. So SARS-CoV-2, however, has a specific structure that allows these appendages or binders to bind 10 times more tightly than any other SARS virus that has been around before. The most common SARS virus is the common cold. For many years, we tested for the SARS virus, and it's the common cold that we test for. The difference with this is that this structure binds 10 times more tightly, and it becomes almost like glue to the cell receptor. The spike protein on this site contains and recognizes, it activates an enzyme called furin, and we talked about furin. Furin is the host cell, and when it says it's the host cell, it's like you at your dinner. You're the host. So the cells of your body take this furin in as the host, and they attack various human organs, such as the liver, the lungs, and the small intestines. And these are areas that are very, very vulnerable for patients. The fact that this enzyme resides, furin, in all human tissue means that the virus can potentially attack any or several organs at one time, which is why this COVID-19 virus is so deadly. It can attack the kidneys, the liver, the lungs, the brain, the skin, all at one time. And then they bind and attach, and it becomes very, very deadly. Next slide, please. Okay. So studies have been reported among most frequent neurological features of coronavirus, complicating 2.8% of COVID-19 patients, according to a recent report that was done by 11 Northwell hospitals. So when this pandemic started, Northwell, being the educating organization that we are, looks at some of the research of this, and they've done extensive research on this pandemic. Studies have suggested that bacteria and viral infections may be a trigger for the acute ischemic stroke, probably related to the blood clotting factors of the inflammatory response of COVID-19. Next slide. So in a retrospective study, and that really simply means that this is a study that was done after these patients left, of hospitalized 19 patients in the Northwell system, 5.7% of them suffered a severe stroke. So out of 214 patients, 19 patients had a stroke. Now that doesn't sound like much, 19 patients, but when you have a small sample like 214, you get a ratio of 5.7 of them had severe strokes. So when you look at these two slides that I have here, this is an example of a large stroke on the bottom where you see the brain. That big dark spot is the area of a stroke. You can go to the next slide. So is stroke and COVID-19 different? Yes, very much so. Patients that suffered strokes during having COVID had worse neurological admissions and prognosis. So it means that the neurological findings that we had on those patients that came in were much more severe on admission, and their prognosis was worse on discharge. There was also a much higher mortality rate of patients that suffered from COVID-19 and also had strokes. Of the patients that were seen in the whole Northwell system, between 10 and 30% were higher rates of stroke. The 30% was much higher across the country. When you look at what the care of stroke patients are across the country, there are very many more disparities depending on where you live. If you lived in a rural area opposed to living in a city, if you lived in an area that had the access to care very quickly, if you lived in an area where the rate of COVID was higher, For example, in the height of COVID, New York State was almost the epicenter of COVID. We had a very, very high rate of COVID, which means we had a very high rate of mortality in the beginning. We also found that patients who had COVID-19 and strokes had a higher frequency of large vessel disease. And if you look at this stroke in this big picture that I have here, this black spot here is a stroke of a patient that had COVID. Normally, we don't see strokes this large, but for patients who had COVID and had strokes, they had much larger strokes. We also saw a higher prevalence of patients with atrial fibrillation. Atrial fibrillation is one of the risk factors that can cause a stroke normally. But because of patients that had COVID and they had a higher rate of blood clots, atrial fibrillation was a much higher percentage. I see there are two questions in the chat. Do you want me to answer those questions first, the moderator, or do you want me to wait till the end?
Completely up to you. Yeah, your discretion.
But let's look at those two questions now because they may be related to the slides that I just covered.
Sure, I'll read them out loud to you. Does a continuously elevated D-dimer 9 months after an active infection increase the risk of blood clots or stroke? Is the first part.
So a D-dimer is really a diagnostic test. And what that D-dimer shows is that there's inflammation somewhere in the body. And very often patients with who've had COVIDs have very high D-dimers post-COVID. It could be that this is a predisposition for something, or it could also mean that sometimes these D-dimers are giving you false positives or false elevations because of the inflammatory process. That's something that you're best to discuss with your primary care physician because they would likely run other tests to determine if that D-dimer is accurate or not.
If there is this risk, should a blood thinner such as Eliquis 2.5 milligrams twice a day provide any protection?
That is a question for your primary care physician. But if you're on a blood thinner, more than likely your physician is giving you prophylactic medication to prevent any further issues. I hope that's answered your questions.
Yeah. Have any clinical studies been done following long-term effects of COVID in this regard?
So unfortunately, because COVID is only 18 months old, and it's way too long for all of us, I'm sure, long-term studies are not totally available at this point. Research is ongoing every day with this crazy virus and this pandemic. So there is plenty of research out there, but there have been no conclusions just yet that I'm aware of.
And should a possible COVID-19 treatment include blood thinning drugs like Pradaxa, et cetera?
So when I get into some of the slides in further, you'll see that each patient has to be taken as an individual. And there are many other tests that go along with that to determine whether or not the patient should be on a blood thinner and what blood thinner is appropriate for them.
Okay, great. We're good to move on.
Okay, so mechanisms of stroke and COVID-19. So through research and looking at all of the strokes that did occur, we found that there were 4 areas of mechanisms that caused or may have been a predisposition for the stroke and COVID. So the first is that COVID-19 may predispose you to a stroke by several direct and indirect means that induce cerebral vascular pathologies. Primary vasculitis. And vasculitis is really an inflammation of your vesicles. It's an inflammation of your veins. It causes inflammation. It allows your veins to become sometimes brittle, sometimes narrower. Cardiomyopathy, and that is an element of the heart where your heart does not work at 100%. Hypercoagulable states, and that's where you have difficulty with clotting. It could be that you are making too many blood clots or that you're not making enough of blood clots, making clotting factors. But with COVID-19, it showed that there was an area of many blood clots. And then endothelial dysfunction. And that simply means that the endothelial is the lining of your vessels. There was a dysfunction because of the inflammation from the vasculitis. So that's one reason. The coronavirus surface spikes protein bind with something called an ACE2 receptor. Now, if you have a cardiac condition or high blood pressure, you may be familiar with some of the medications called ACEs and ARBs. And that's an angiotensin receptor drug or an angiotensin drug to lower your blood pressure and your heart disease. These receptors with COVID-19 attach to the endothelial cells of smooth muscle. Your heart is smooth muscle. Your veins and arteries are smooth muscle, resulting in an acute coronary syndrome or blood clots in the heart or in the brain, and that's what causes the stroke. Now, several of the treatments early on in COVID was, do we continue to give our patients ACEs and ARB medications, or is then this going to impede or cause them to have further strokes? There was no change in patients' medication. If you were on an ACE inhibitor or an ARB, you needed to stay on those medications. Taking you off those medications was not an option at the time of your acute COVID virus and stroke. We did find, however, though, that it did bind more to these inhibitors in your bloodstream. The coronavirus suggested a complete inflammatory response. This reaction predisposed the inflammation and the rupture of plaque. So very often strokes are caused by plaque breaking off. Well, the body during COVID was in such an inflammatory response. Every organ and every system of your body was inflamed due to this COVID infection, that it very easily caused plaque to break off. So if you had atherosclerosis before, if you had a high level of LDL or HDL or cholesterol, you're predisposed to this plaque. And that's one of the predisposing factors that may have caused plaque to go off and to injure the left atrium, ventricle, or your cerebral blood vessels, causing a clot and ultimately causing a stroke. And the last thing that we found on all of the research that was conducted is that the coronavirus can also produce an acquired hypercoagulable state, which causes blood to be unable to flow freely through the arteries. What happens is, as these blood vessels have inflammatory process, they shrink and not allowing the blood to go through. When the blood cannot go through, it causes some clotting. And those are the four factors that were conducted in research that were determined to cause the increased rate of strokes in patients that had COVID-19. Now, if you look at this, some of these were predisposing factors. If you had high cholesterol, if you had high blood pressure, that predisposed you to having an ACE or an ARB. If you had high blood pressure, you may have been on a blood thinner. If you had high cholesterol, you're prone to plaque to begin with. If you were a diabetic and you had COVID, you already have an inflammatory process in your body. So this is why those patients were at such high risk for COVID-19. Your hypertensive patient, your diabetic patient, your patient that had atherosclerosis. Those patients were at such high risk for COVID, which is why it's so imperative that those patients moving forward make every effort to get a vaccine to prevent them from getting COVID and ultimately prevent them from possibly having a stroke. Next slide, please. So are COVID-19 stroke patients adequately treated? So we looked at that as an organization and as Northwell. We wanted to make sure that even though our patients were coming in with stroke and were being treated for COVID, how were we managing them? We really didn't change a lot. Our early management of stroke care remained the same. Our patients that came into the emergency room were seen extremely quickly when they came in with COVID and possible signs of a stroke. We call our stroke codes in the emergency room here code oranges. When we did our research, we found that there was no time difference. There was no delay in treatment of our patients who came into the emergency room with a suspected stroke and COVID-19. They were still seen as quickly as possible and treated as quickly as possible. And they received the same treatment that we would have if they didn't have COVID. We still would have given them the aspirin. We still would have done our CAT scan within 10 minutes, had our physician see them within 10 minutes, start them on a lipid if they had lipid reducing medication if they had high cholesterol. Look at the blood pressure. We still would have managed the blood pressure. The options of clot busting medications such as TPA or endovascular treatment, where we can go and pull that clot out of the brain, were still done. They were not contraindicated if you had COVID. So we still managed our patients the same way that we would if they didn't have COVID. However, despite all the timely treatment, TPA, favorable post-thrombectomy, where you take that clot out and that blood circulation goes right through, patients with COVID-19 and acute stroke had much poorer clinical outcomes than patients who didn't have COVID-19. Next slide. Are there two new questions, or are those the same questions that we just didn't take off?
Those are the same ones.
Okay, great. So how are clinicians treating COVID-19 patients who have strokes or clotting issues? So given the high risk for clotting, especially with severe COVID-19 illness, it makes sense to administer blood thinners such as heparin to prevent blood clots in the brain, the lungs, the legs, and other tissues on admitted patients. However, this strategy needed to be balanced against the small risk of a bleed in the brain. So because the blood vessels of patients with COVID-19 were in such an inflammatory process, sometimes they became very weakened. And we had to make sure that the amount of blood thinners that we were given were not too much or too little. It was a very, very fine line that our physicians had to walk to make sure that our patients got the adequate blood thinners that they needed. We couldn't give too much because we didn't want to risk a bleed in the brain, which is called a hemorrhagic stroke, which is a different type of stroke. And we didn't want to give too little blood thinners because we didn't want to cause more blood clots. So we had to balance each risk factor with that. In patients presenting to the hospital within hours of a stroke onset, there was no evidence that we needed to change our management. So for patients who came in within the 3 to 4 hour window of allowing them to get the clot busting drug of TPA, we were still able to do that. It's when patients delayed coming in. And we found that during COVID, patients were so afraid of coming to the emergency room that they were coming in much later with symptoms of stroke. They weren't getting here sooner than the 3 to 4 hours. They were waiting very long at home because the symptoms were masked by the COVID symptoms, that we were very often not able to treat them with TPA or clot removal, which caused these strokes to be much more catastrophic. Routine inpatient management did not change at all during COVID-19. As I said earlier, patients still received their aspirin or clopidogrel or warfarin or Bixaban, and the others were given different things to prevent stroke progression. So we give these medications because we don't want to have more clots. We don't want to have the ability to say that we couldn't give patients clot busters because they came in too late. We wanted to manage those patients the way that we did all along, and we did very well with that. It was essential, though, to control blood pressure and blood sugar levels to prevent complications such as aspiration pneumonia, and you needed to treat the fever of these patients immediately to prevent any further infection of pneumonia. Most often, COVID-19 went right into COVID pneumonia, and that's where things became very, very tricky. because when you have COVID pneumonia, not only then do you have inflammation of the blood vessels, you have inflammation of the lungs. And when you do not have good air and blood exchange in the lungs, you have much more increased risk of blood clots in the lungs. A blood clot in the lung will predispose or be a primary factor for anyone for potentially breaking off and that blood clot going to the brain, which would then ultimately cause a stroke. Next slide, please. So stroke and COVID-19, predictors and outcomes. So the complex interaction, Northwell did an amazing study, and there's a complex interaction between aging, weakness of patients, delirium, confusion of the brain, and patients that were hospitalized with severe COVID had a distinct stroke imaging patterns and even more abnormal laboratory biomarkers, which support a potential link for supporting that COVID-19 alone is a strong independent risk factor for stroke in hospitalized patients. So not only for a patient that was admitted with high blood pressure, diabetes, and heart disease, adding that COVID-19 virus caused these patients to have an increased risk factor for stroke. So Northwell did a great study, and they did a study very early on. And that is one of the benefits of being associated with Northwell now, as Mather is. We have so many more networks and resources for us as a community hospital to allow us to do some great research and be very proactive for our patients coming into our hospital. Northwell found that 90% of fatal cases occurred among patients over 65 years of age, where the death rate was as high as 44%. So of 143 patients, 63 of those patients passed away over the age of 65. They also found that patients with weakness was a strong predictor for survival. So if you were over 65 and you were a weak person, if you were not strong, you had maybe rheumatoid or other factors that made you weak, high blood pressure, heart disease, if maybe you were not as agile, not as physically active, your survival rate of hospitalized COVID patients was much higher with stroke. And the biggest thing that we found is stroke patients are rated on what they call an NIH stroke scale. And this stroke scale was put in place by the National Institute of Health stroke scale. And it goes from 1 to 32. And the higher that you are on this stroke scale, the more severe your stroke is. So for example, if you came in and you had an NIH stroke scale of 2, it may simply mean that you had a little weakness in a right hand or a little weakness in a leg. It's usually not a very large stroke. It's considered a mild stroke. However, we found that patients who came in with COVID-19 and stroke had much larger strokes. The average NIH stroke scale on a stroke patient is around 8. That's a predictor of the severity of a stroke. Patients that had strokes and COVID-19, they presented with an NIH stroke scale of a minimum of 19, which is twice the severity of a stroke. So we not only found that patients that had COVID-19 and other risk factors were likely to have a stroke, but they were also likely to have a much more severe stroke. Next slide, please. So this was a retrospective study, again, a study of patients who were discharged of COVID-19 concurrently diagnosed with stroke. So this was patients that were diagnosed with COVID-19 and stroke. And it was only a very short time period. It was from March 14th, when we started the whole pandemic lockdown, through April 20th. So it was a little over a month. And it was done by 11 Northwell hospitals, both on Long Island and in the city. And our sister hospitals in Queens and Manhattan had much more prevalence of COVID than we did out here. So this study looked at emergency room patients who came in with a neurological evaluation. And the number of patients that were put into this study were 505. And of that, 358 of them were COVID negative, 147 were COVID positive. So if you look at the COVID negative patients that came into the emergency room, 29% of them came in for stroke, 23% had other things, could be a UTI, could be cardiac disease. And the ratios of patients in that 358 were our normal ratios. They may have had 5% had delirium, 7% were diagnosed with a headache, 6% had what they call a stroke that was a bleed. But when you looked at the patients that were COVID positive, of the 147 that came in, 35% of them had a stroke. 10% of them had some form of encephalopathy or a swelling of the brain. 16% had a form of delirium and were much more confused and disoriented. So you'll see that even though it was a smaller number of patients that were positive, they had much higher negative outcomes, long range. Okay. So is there anything that patients can do to prevent strokes? And pretty much, yes. So we want to be able to say that, yes, we want to prevent strokes and COVID. They go together. It's essential to wear your masks and follow the social distancing guidelines and hand hygiene to reduce the risk of a viral infection. Now, I know we're all tired. I know we've all had enough of a mask. I know we just want to get back to our normal lives. Believe me, nobody wants to get back to normal lives in the staff of the hospital. It's very difficult for our staff. We want our community to get back also, but we have to practice following these guidelines. The bigger things is that we want to prevent the stroke from happening to begin with. So following that healthy diet, lowering your cholesterol, getting in regular exercise. Now, this was kind of difficult during the pandemic. We were isolated, we were in, gyms were closed. But I will tell you, people became very resourceful. Every morning on my ride to work, I would see a group of people at the Wedge, or it's a local park that we have. And even though the gym was closed, they were social distancing and they were weightlifting and they were jogging in place. They made the best of what they had to do to keep up with their regular exercise routine. Some of the biggest things are smoking cessation. Smoking alone will make you 10 times more prone to a stroke than a non-smoker. Smoking causes the plaque that builds up in your arteries and your veins. And when that plaque breaks off, that's where we have our strokes. Also, medication compliance. It became the pillar of stroke prevention. During the pandemic, it became difficult for patients to see their primary care physician. Many primary care physicians went to Zoom or tele visits. It was very important that they even kept up with these tele visits, because getting your medications reordered was extremely important, and it continues to be extremely important. It's one of the ways to prevent your stroke, medication compliance. If you are scheduled to take an aspirin a day, taking that aspirin a day is very important. Not taking 2 aspirins, not having your aspirin at all, that's not what we mean. If it's once a day, it's once a day. If you were scheduled to have hypertensive medications or diabetic medications, it was imperative that you continue those medications. There are many, many programs out there to help if you need assistance in paying for some of these medications. So while there is some evidence that certain blood pressure medications, and we talked about this, ACEs and ARBs, can facilitate the COVID-19 infection, these drugs are also beneficial since they reduce the lung injury in viral pneumonias. Even though there's the possibility that this virus attaches to those ACEs and ARB preceptors in the lungs and liver, it's important that we continue to take our medication and not recommend stopping or changing our ACEs and our ARBs. That is very, very important. Very many times a patient would come in and they'd say, well, I read certain things and ACEs and ARBs caused COVID, so I stopped taking my medication. All they really did was make their potential of having a stroke much higher. Next slide, please. So this alarming trend points to the need to focus the attention and action on improving cardiovascular health of all Americans by helping people avoid unhealthy behaviors that put them at risk of heart attack and stroke, and improving the care of those key risk factors. So some stroke statistics. Despite the fact that we had over 1 million people die of COVID, more than 1.5 million people every year suffer from heart attacks and strokes. More than 800,000 deaths a year occur in the United States from cardiovascular disease. So many of you will say, well, we had 800,000 deaths from COVID. This is an additional 800,000 deaths. So we were not able to prevent these. We can prevent cardiovascular disease and stroke. We could lower these deaths. Cardiovascular disease costs the United States hundreds of billions of dollars a year in rehab costs and medications and care for our patients. And it's the greatest contributor to racial disparities in life expectancy. Unfortunately, minorities like Hispanics, Afro-Americans, and Asians have the highest rate of stroke and cardiovascular disease. And that is one of the disparities that we have as a society that we need to change and prevent further strokes and heart disease. Next slide, please. So the aim of that is to prevent 1 million or more heart attacks and strokes over the next 5 years. So this is the Million Hearts campaign. This is a national initiative that was co-led by the Centers for Disease Control, or the CDC, the Centers of Medicare and Medicaid, CMS, and they're going to partner all across federal, state agencies, and private organizations. Northwell fits into that private organization. And we've teamed up with the American Heart, American Lung Association, American Stroke Association to be part of the Million Hearts and the Million Lives campaign. Next slide, please. So the Million Hearts 2022, the aim, as I said, is to prevent 1 million heart attacks and strokes over the next 5 years. And if you look, the biggest hub there is our community, and that's our hospital. May not look like Mather, but it is our local community hospital, whether it's us or one of the other local community hospitals. We will be optimizing care of our patients in the community and doing many, many more educational pieces as a primary stroke center to keep our patients and our community healthy. Not only will we be keeping our patients and our community healthy, we will be looking at working with our employees and adding them as our customers also, because it is imperative that our patients, as long as our employees, maintain a healthy lifestyle. Next slide, please. So what are these priorities? So the keeping people healthy. When you look at that, we want to reduce the sodium intake of our community. So you'll see many, many more restaurants offering healthier meals. And as a member of the community, we will be teaching lower sodium diets. Our patients will be getting the choices of much more healthier meals here. At Mather Hospital, we've switched to all fresh vegetables. We've switched to a much healthier way of managing our meals for our employees and our meals for our patients. We've looked at optimizing our menus to offering lower sodium intake foods. We've gone to making fresh soups, opposing to have a canned soup in our organization. So many, many more things. Going to more of a fresh dessert and preparing more fresh desserts here than having more prepared desserts. We're looking at decreasing tobacco use. We're very proactive on offering tobacco cessation programs to our patients. plus offering cessation tobacco programs to our staff, offering discounts on things if they participate in tobacco cessation, and increasing physical activity. As employees here, we recently participated in, we called a March to the Caribbean. So we're promoting health within our own organization to our own employees, because we need to lead by example as an organization. As we promote a healthy lifestyle to our employees, we're also hoping that this will rub off on their family members and have more of a healthy lifestyle in the community. We want to optimize our care of the community. We want to improve the ABCSs, and that's looking at aspirin when it's appropriate, blood pressure control, cholesterol management, and smoking cessation for our community. These are the 4 pillars of improving stroke and cardiovascular care in the community and preventing stroke and heart attacks of our patients before they come in. We want to look at increasing the use of cardiac rehab. Recently, we opened up a cardiac cath lab here at Mather, which has now given our community the opportunity of staying right here from Mather for cardiac care that they may need, preventing them from a stroke. We're looking at improving things like cardiac rehab down in the future here at Mather Hospital. Setting our patients up with a form of cardiac rehab at discharge, maybe not here, but somewhere else that works for them. Cardiac rehab is so imperative for our patients because it gets them back to the level that they need, but it also gets them into regular exercise habits. And statistics and research has shown if you do anything more than 30 days, that becomes a habit. So a cardiac rehab program extends more than 30 days. And we want our cardiac patients to get into a good exercise program so that they will continue to do that. We want to engage our patients in a heart-healthy behaviors. These are things that will lead them into heart-healthy life and prevent them from having heart attacks and strokes. Now, the biggest thing to that is improving the outcomes for priority populations. We have to, as an organization and as a community, improve our outcomes for our Black and African Americans in the community, improve the education to them, improve the knowledge base that they need to have and to prevent them from having strokes and heart attacks. So also looking at our 35 to 65-year-olds, that's the key. Getting education at a younger age. If I can get a 35-year-old who's in poor shape, they still smoke, they're eating a lousy diet, they don't do any exercise. If I can get them to change their lifestyle between 35 and 64, they will have a much better outcome and if they have a heart disease and stroke. And people who have had heart attacks and strokes, we need to prevent them from having a second heart attack or a stroke. The only way to do that is through a lifestyle change. So we must encourage lifestyle changes, lowering that sodium, decreasing that tobacco, and increasing that physical activity. Unfortunately, the pandemic has increased the amount of mental illness and substance abuse disorders in the community. And it's a known fact that we've had a higher rate of overdoses during this COVID pandemic. We've had a much higher rate of depression and mental illness during this pandemic. We have to be able to treat mental illness and substance abuse disorders so that our patients in the community will have a healthier mindset to manage these lifestyle changes. Next slide, please. So keeping people healthy. So our goal as an organization in Northwell is to reduce sodium intake, as our target is by 20% of the population. So we want to enhance consumers' opinions of lower sodium foods. The Institute of Healthy Food Procurement and Nutritional Policies. We want to be able to have our food banks and things have much healthier foods. We want to work with our community to lower sodium intake in our community. We want to enhance smoke-free spaces and policies that include e-cigarettes. So even as we are a campus that has a smoke-free policy, that includes e-cigarettes. We don't encourage that. We don't want it on our campus. It's not allowed on our campus. But we also want to look at that in the community. We want to work with our community legislators to look at e-cigarettes, maybe pricing approaches as a community, and conduct mass media campaigns. Northwell itself will be conducting mass media campaigns moving forward, especially during Go Red Month, especially during October when we have National Stroke Day. And we want to encourage and enhance physical activity. We want to reduce inactivity by 20%. And you'll see as an organization, we lead by example. We have encouraged our employees to participate in our walk to the Caribbean. We've looked at some very good stress reducers for our employees because we feel that we must encourage a healthy workforce for our patients, because we have to have a healthy workforce from within to encourage that healthy environment for our patients in the community, but also to be well enough to care for our community as we have an influx of more patients with COVID and strokes and heart disease. Next slide, please. So we want to improve our outcome in priority populations. So as a primary stroke center, we will be reaching out to the community and targeting more of our areas that have Black African American population and hypertension. It's great that we do these HealthyUs, but we may need to bring these HealthyUs moving forward to them. It may be difficult for them to come to us. Looking at the 35 to 64-year-olds, improving hypertension control and statin use, and decreasing physical inactivity. We need to promote more physical activity in our community. We're going to be doing some more target populations, community-based educations through our stroke program here at Mather. And looking at people who've had a heart attack and promoting increased cardiac rehab. One of the things that we do if patients were discharged from rehab, from cardiac care here, we're looking at cardiac rehab and making those referrals ahead of time. Maybe looking at some automated referrals. Having some good liaisons here to work with our patients and offering vaccines during routine hospital care here. And we do that. We offer the flu vaccine, we offer COVID, we offer things like that, or promoting things in the community. It's very, very important that we promote more as an organization, and we do that. This webinar is a perfect example of ways that we will be leading this charge of improving community outcomes. People with mental illness very often have a very, very high rate of tobacco use. One of the things that we're looking at in our mental health clinics is integrating tobacco cessation into behavioral health treatments and looking at substance abuse treatment on our campuses and to tailor quitline protocols. Our behavioral health group and our partial hospitalization is working very, very hard on this. Next slide, please. So in conclusion, both ischemic and hemorrhagic strokes are at a rather higher frequency complication in patients who've had COVID-19. Stroke itself may occur before the onset of COVID-19 and represent in the first manifestation of the infection. So we've also found that patients that come in with COVID in the early stages of COVID is when they present with their strokes. Stroke might also follow several weeks post-COVID and become much debilitating, much more debilitating. COVID-19 related stroke patients are at a higher risk for poor prognosis and have a higher rate of mortality or deadliness, even controlling the multi-organ failures and the weakness. And in COVID-19, strokes are guaranteed the same treatment and cares as a non-COVID patient. So the biggest thing is that we want patients in the community to know that whether you have COVID-19 or not, you will still be given all of the care for stroke here at Mather if you had COVID or you didn't have COVID. So I believe that's the end of my presentation. I'm open for any questions.
Thank you so much, Joanne, for joining us today. If you do have
My
any
pleasure.
questions, please feel free to enter them in that Q&A spot at the bottom of your screen. We'll leave that open for a little while longer. I just want to give everybody the heads up as well. You'll be receiving a link to view this recording once it's processed through our database. And you'll be receiving a link to complete a survey just so we can hear any other topics that you may be interested in learning about for upcoming webinars in the new year. Looks like we are good to go here. No further questions. Joanne, thank you so much for taking the time today to present. And
Thank you. My pleasure.
Great. And everybody enjoy the rest of your day.
You also. Thank you.